Well, hi, everybody. Welcome to another Shop Talk. Today, our guest is Mark Thomas, who's the author of a recently published paper in Musculoskeletal Science and Practice. We're getting more of these papers in Shop Talk. The Attitudes and Beliefs About Manual Therapy Held by Patients Experiencing Low Back Pain, a scoping review. Hi, Mark. Thanks for agreeing to speak about your paper. Can we start by just you telling us a little bit about yourself, your training, your current role, and your background as a researcher?
Of course. So first of all, thanks for the invitation, Chad. I really appreciate this opportunity to have the discussion and talk about the paper with you. So in terms of me, I'm a chiropractor by background, qualified at the Welsh Institute of Chiropractic, and I think I'm one of the only chiropractors that hadn't actually received chiropractic treatment before I started. I worked in private practice for a number of years and certainly carried out a lot of manual therapy with a lot of great results. Through chiropractic, I was introduced to Don Murphy's work on protocols for spinal pain. Then I became quite interested in mechanical diagnosis and therapy, or McKenzie technique, and integrated that as more of a hands-off approach as well. I then ended up doing an MSc in rehabilitation science. It was a physio-based course at Brighton, which, interestingly enough, I felt was more manual therapy focused than the chiropractic course, very Maitland based and focused. I then ended up working in a MSK triage, a telephonic triage service, and we were sending patients for advanced imaging and assessing patients over the phone, referring them to physio. And I thought that was quite interesting as well, working with new grads who often their perceptions were around the requirement of physical assessment. And of course, that's important. But we know how important that history is and how powerful that is and how it redirects your reasoning. I then ended up working for a physical therapy department. And I know physical therapy elsewhere means sort of physiotherapy and synonymous with that. But in the UK, physical therapy isn't really a term that's used. So the idea behind it was that it actually incorporated chiropractic, osteopathy, physiotherapy, sports medicine. And we had a really sort of professional over profession sort of ethos, really. And that was a fantastic place to be with great people and learned a lot. And then I entered full-time academia, education at London South Bank University with the start of a new chiropractic program. And I've been there for several years. And then I've started my PhD part-time a couple of years ago. And because of that, I've not actually practiced myself privately for the last couple of years, but I am actively involved in our student clinic, supervising the management of patients there. So that's me, really.
We were talking offline, and you mentioned that you see yourself more as a manual therapist than as a title or a particular profession. Do you mind discussing that again?
Yeah, I think so. So I think it was sort of, Ron McKenzie's words, actually, to be a chirotherapist or a physiopractor. And I think, there's so much integration and crossover, especially when we're looking, and practicing what the evidence tells us, and we're being patient-centered. So the overlap and crossover between the professions of chiropractic, physiotherapy, osteopathy, all the MSK professions it's just there, as well as sport rehabilitation, sport therapy. So for me, it's about that person and the practitioner, the professional, as opposed to the profession. And that's really the way I like to think and work, really.
I like that. I appreciate you sharing that. We're here to talk about your paper, and first of all, thank you for writing it, because I get a lot of people that ask me, what do people believe about manual therapy? What are their thoughts and attitudes? And I always had to pick and choose among a number of papers, and now you've consolidated it into one particular paper. What we're about here in Shop Talk is really looking, pulling back the curtain and finding out what was the impetus behind this? Why did you decide to do a scoping review on this?
So I think it's sort of put together from a number of my sort of interests, really. One was my relationship with manual therapy, working in different settings from different professional perspectives. The other, I think, got an interest in particular manual therapy around the sort of safety and interest in risk, and particularly around sort of perceived risk as well of manual therapy. and how that's often quite different to what the literature says in relation to actually how safe manual therapy is, and then how that then equates into different sort of insurance packages for different healthcare providers. Always been interested in the sort of psychosocial aspects of care and contextual effects, and in particular in beliefs, what people think, what people feel in general, and then I was interested in what work Ben Darlow did in relation to low back pain beliefs. And then the idea really was shaped and formed from speaking to clinicians, supervisors, researchers, and patients actually as well. So as part of my PhD, so I'm doing a part-time PhD, which is the scoping review is part of that. Have a sort of a patient and public involvement group, and huge input from them really in terms of getting their perspective, because obviously they're the center of what we do, and this is all focused on what patients think and feel. So really I sort of formed that topic for the PhD out of interest, but also I think there's that gap in the literature, and I think that gap's there, and that gap's used to form some assumptions that maybe aren't backed up by some evidence. So in particular, one is around the safety of manual therapy and how that's perceived, and the other, which I know you're interested in and spoken written a lot about, as well as potential of the assumption about the reliance on passive care and reduction in self-efficacy or decreased engagement in self-management approaches associated with manual therapy. And I don't think that the literature supports that, but there's certain assumptions that are made in the literature by policymakers in clinical decision making. So I wanted to sort of address all those things and sort of bring everything together really.
Yeah, it's great foundational work. And if you don't mind, do you mind just discussing again what a scoping review is for our listeners?
Yeah, of course. So again, lucky doing it as part of my PhD, because I sort of did quite a lot of investigation into different review types out there. Most people are probably more familiar with systematic review or even narrative review. Scoping review is a bit less well known sometimes, and systematic review is often considered the gold standard. But of course, it depends what the question is that you're asking, and what a scoping review is all about is having a wider net, a broader view, and really looking to sort of map the evidence that's out there. And it still is rigorous and transparent, but it's probably got a bit more sort of flexibility and reflexivity in relation to it. It's still going to follow that protocol through. There's frameworks out there, framework that I used, and there's a Prisma extension that's used for it as well. But as I mentioned, it's more of a broader question rather than a direct clinical question, which sometimes a systematic review would follow and take. So often it doesn't appraise the literature, because it's not the quality of the literature, because it's not looking to do that. It's more looking to see what's out there, what do we know, how are things looked at, and in mine in particular, how are attitudes and beliefs sort of measured and explored. Can often include the grey literature as well, because it's sort of broader. And then, as I mentioned, follow a framework. So mine, for example, was following the Arsky and O'Malley framework, which is sort of 5 points. 1, develop your research question. 2, identify the studies via a search strategy. Number 3, study selection, which studies are going to meet the inclusion criteria you're going to include. Chart the data, which effectively is data extraction, taking out that key information out of the included studies, and then analysis and or synthesis. And in a scoping review, often that's a descriptive summary of that data, and also a qualitative analysis to look for themes as well.
So you ended up with 14 papers, and you divided your findings up into 5 categories. And I'm just going to, or 5 themes, I think what you called them. Negative outcomes with manual therapy, mechanisms of manual therapy or how it works, preferences, patient preferences for manual therapy, patient perception of manual therapy, and then patient beliefs about the effectiveness of manual therapy. Did you have those in mind before you actually looked at the papers, or did you develop those themes as you looked at the papers?
Yeah, so I think I had some in mind, but I certainly developed them as I went through, and that was done as part of the research team. But I think some of the ones that are out there are more well known. For example, adverse events or negative outcomes. So that was clearly a one with a little bit of literature and focus on. I think the mechanisms of manual therapy is probably a newer one, and to take as a new theme. So that was probably a new one to look at. So it was a combination. Obviously, I knew the ones that would be out there, knew somewhat what to expect. There's a tool which we might talk about that's used to capture some beliefs around manual therapy in patients, and that uses a number of sort of themes or areas. So I knew that was out there as well, but largely took them from the data that was there.
And I really liked your introduction. So I'm not a big introduction guy. I skip the introduction. When I write a paper, I usually write the introduction last. So I've got a couple of questions. The first one, when did you write your introduction? Did you write that first and then go into it, or did you wait until the paper was pretty much done? And secondly, how did you do such a nice job of packaging the quandary around attitudes and beliefs and such? I mean, what was your secret behind writing such a good introduction?
Okay, well, thanks, Chad. Thanks for the. I think honestly, I can't remember which I did first, if I'm being honest, and two reasons for that. One is, as it was part of my PhD, I'd done a lot of sort of work and writing around that subject as well. And two, so I think it's the area that I struggle with the most, the introduction, and really sort of takes that time. So I probably had a few different versions which really helped to shape, develop, and improve it. And of course, going through the peer review process as well really helps shape and develops and improves it. And I think I really just wanted to be clear about what the problem was and what I was setting out to do, and just to try and write with sort of clarity and flow. But that's a real challenge. I think something that helped me is, again, through my PhD, I had people that look at my work, and I had to sort of support my work to people that were in healthcare but were outside of manual therapy. And I think if people are outside of manual therapy, I think that can be, it's even more important to really articulate what I'm trying to do and what I'm trying to look at. So I think that made me really reflect, and maybe stepping outside of that, of just the sort of manual therapy musculoskeletal world, and also write it for an audience as well for healthcare, but outside of that specialism. But certainly introductions are a challenge, and that's definitely still a work in progress for me, I'd say.
I think it is for everyone. And yeah, I know you're keen on the patient voice. Did you have patients look at your writing to give their input on this?
I'm trying to think if I did directly in relation to the introduction. I don't think I did at this particular stage. Patients mainly came on board to help design the next few phases, and look to see the sort of literature, the information that I'm giving to prospective patients that I'm going to interview or work with on the next few stages. So probably they're more involved in the overall design, the question I wanted to ask, and then the literature that I'm going to give to potential participants. I don't think they were directly involved in reading this element and this aspect as such, but I feel like on reflection, I might have missed a trick there actually, and then again another area for patients from that group, my patient and public involvement group, to be involved with. So yeah, I missed a trick there.
No worries. I'm sure I'll catch it as you continue on with your PhD studies. Within the 5 themes you identified, actually quite a few papers that covered each one of those. Of those 5 different themes, is there any area that surprised you the most, or that you were thought was most compelling?
Yeah, I think just sort of reflecting on that, I think was maybe around the negative outcomes, and maybe around the fact that I knew there would be that theme of negative outcomes of adverse events, but I think what I found quite interesting and different was the fact that it was really sort of accepted and common for this post-treatment soreness. And often if you think about manual therapy, and people talk about manual therapy, adverse events are often blown out of proportion and aren't necessarily in line with what the true risk says. So I thought that maybe there would be more critical views from patients around these negative outcomes, whereas it seems to certainly be part of it quite accepted, even to the point where actually this is something I did discuss with my my patient group, and actually a thought that they had was that actually maybe patients feel that for manual therapy to be effective, then they need to feel something afterwards, almost a no pain, no gain approach. So I thought that was really interesting. And also as part of that, I found it quite interesting how it appears that there may be some differences as well for preferences for different types of manual therapy, and potentially that maybe manipulation might be viewed as more risky, which of course makes sense and is maybe not that surprising, but it's related to this sort of biomechanical or biomedical view of the mechanism. So that's the area that I probably found more surprising and more interesting.
Yeah, let's unpack that a little further. I know you quoted one of our papers, Donaldson et al., in which we actually looked at clinician-determined irritability, and then also looked at preferences of mobilization versus manipulation, and there seemed to be a relationship with that. Did you find any other papers that looked at that or tried to sort out why there were preferences toward manipulation or mobilization?
Yeah, so I think yours was the main one. It was really interesting in that detail it went into, this sort of irritability element, and also some other factors that came up. So sort of BMI as well, a factor which associated with preference. I think the other main papers that looked at it from that perspective were more a couple of the qualitative papers that explored it a little bit more and explored what patients really felt was happening in terms of the manipulation and how they viewed that as a risk. And again, that's how they viewed it in relation to the biomechanical things that were happening. They viewed that potentially, the sort of classic thing where the spine was out of alignment and therefore manipulation was then realigning this, and nerve was trapped, a nerve was freed via the manipulation, or something of that nature. So I think it was more the qualitative work that explored that. But I think from looking through the studies, that wasn't necessarily the focus of what they were looking at. That sort of came up. So I think it's an area that certainly could be explored further, and that's something that I intend to do to look at that. I think often manual therapy is collected and looked at as a group, actually, without differentiating and separating it out. So I think certainly, there may be these sort of subgroups where patients do have strong preferences towards one or the other based on either their positive expectations or their worries about negative outcomes.
So you brought up that they felt that there were biomechanically related mechanisms, and we know now, obviously, that that's not the case. Historically, that's what's been advocated. I think there are selected professions, I think, that push this quite a bit to really explain why. I want you to put your teacher hat on for a second, and the fact that you straddle multiple disciplines. How do you instruct your learners about the mechanisms of manual therapy, especially when we don't fully understand what's happening? I mean, what's that conversation look like with your learners?
Yes, that's a great question, and it's really a challenge. And I think it's probably a challenge between 2 points and two sort of extremes that I've found myself in or viewed people doing. One is that you focus purely on a biomechanical point of view, and you focus on that to ensure that you get development of the key sort of psychomotor skills, and you do it as a way to aid the initial understanding of students, to enable them to then translate that understanding into the manual therapy they're doing. Obviously, the danger and downside of that is you're then developing biomechanical thoughts and views within them that they could potentially pass on to their patients. I think on the other side, which is a place where I found myself as well, you focus more on the non-civic or the contextual factors there, which is more reflective, I think, of our understanding of what the literature says. What I found, though, is where that can be a challenge is that there's the risk of students feeling that manual therapy is then not a valid skill. It's not a valid technique. It's not a complex psychomotor skill, where they feel that it's devalued. They feel that you're not supporting the modality that they want to learn and that patients have a strong preference for. So I think it's finding that correct balance, but I've definitely found the side where I've had to sort of go back and on reflection, put across to students that manual therapy is effective treatment, is a safe treatment, is an appropriate modality for the right patient at the right time in the right context. And just because what we're doing isn't based purely on the mechanics and the neurophysiology, it doesn't mean that it's not important, and that maybe we focus the skill away from just the sort of psychomotor skill, but also to that communication skill with the patient as well. But again, I find it's quite interesting. One thing we occasionally do with our students is ask them to do an essay, an assignment on the mechanism of manual therapy. And it's quite interesting from an educator point of view. I don't think I've seen so much variability across a group of essays with that topic compared to anything else, because people have such different views across this. Students and manual therapists, that follow sort of different techniques, different professions, view different mechanisms. So it's definitely a challenge, and it's a balance, because we need to develop these psychomotor skills and the competencies within students. They need to be safe, but they need to understand the perspective of where this sits within our current understanding and the current literature. They need to know how to maximize positive outcomes and reduce negative outcomes.
I thought you answered that really well. I'm part of a team that is actually, where terminology-wise, we're defining all the different types of mechanisms, and we're hoping that once we have a better understanding of all the different potentials, it'll improve our ability to have that conversation with the patient. I think one of the real challenges is patients are influenced by the ceremony and the contextual aspect of that ceremony, and if you devalue that in the conversation, it could potentially influence the outcome. So there's probably a happy medium there, which, who knows. So one of the limitations you mentioned in your study was that there was really only one, I think, validated scale that was used in your scoping review of the studies in your scoping review. Can you just discuss that on how that may potentially influence the outcomes of what you found?
Yeah, sure. So in the majority of the studies we looked at, there was significant variability in terms of how attitudes and beliefs are measured. That was often either a single question or an adapted question, or there was some questionnaires, but they hadn't really gone through that validation process, and there was significant variability between them. So obviously you have to take that into consideration when looking at the results, and accept there's some variability in the answers because there's variability in the questions that were asked. And of course, by the nature of the scoping review, we didn't look to critically appraise the studies, but were aware that it was a limitation. And then, so you mentioned there is one validated tool, which is the Low Back Pain Treatment Belief Questionnaire, Dima et al. And that instrument isn't just specific to manual therapy, but covers 4 treatment techniques. So one is manual therapy, one is acupuncture, one is medication, one is exercise. And what is really great for is a really good tool for shared decision making in primary care, and looking into patient choice for these different interventions by comparing them effectively and looking for a preference. However, I guess the downside, the limitation when we're looking at manual therapy in particular, is that it's not specific to manual therapy. So when we're talking about particular benefits or particular risks, they could be quite different, how people view benefits of manipulation versus medication, or in particular how they view certain risks of manual therapy versus risks of medication. So fantastic, great validated tool, being through a really rigorous process. But I think maybe there's room and scope for one that is focused more on manual therapy itself and the nuance of manual therapy.
I've got one last question for you, and this is reflective. We just finished a study where we measured early baseline what the expectations were for patients who were receiving physiotherapy for shoulder pain. And we found that everybody had extremely high expectations about the care that they were going to receive. It really made it difficult to tease out if lower expectations made a big difference. In reading your work, it seemed like most of the individuals had high expectations about manual therapy. Now, it could be selection bias, it could be me just reading through your writing, but you were close to all 14 of the papers. It seemed to me that the patient populations had high expectations about the value of manual therapy. What are your thoughts on that?
Yeah, I think so. So just just thinking about those studies, I think in general patients do have high expectations. They have high preferences for manual therapy. They have high expectations of manual therapy. I guess probably where we need to look at it in a bit more detail is what type of expectations and how those expectations are measured. Is it an expectation of full recovery? Is expectation of improvement in pain, improvement of function? Because expectations in itself is a massive generic term with different types of sort of concepts within that. But on the broader aspect, I think in general, yeah, patients certainly from these studies, and maybe I say this, that could be reflective of the nature of these particular type of studies and the patients that were selected for that. It may be different on different cohorts of patients, and obviously based on their previous experience as well, if they've had manual therapy before or not, expectations of different types of manual therapy. But I guess to answer the question in general, yeah, patients certainly had high expectations of what they expected from manual therapy, which I think is linked into their preferences of thinking that it's a positive treatment for them.
Very nice. So what's your next work? What'll be coming out next?
Well, so nothing just too soon. My main focus and what is my full time in academia, but obviously doing the part-time PhD. So the next stage of the PhD will be looking at a qualitative piece of work exploring patients' attitudes and beliefs about manual therapy a bit further, and trying to dive a bit deeper into some of these concepts. I'm also working, so we've set up a sort of research group with the chiropractic institutes within the UK. We're working on doing a multi-site RCT looking at pain neuroscience education for chiropractic students. And I'm also involved as well on sort of incident reporting, so involved in our incident reporting system that we use in chiropractic, something called CPIRLS, Chiropractic Patient Incident Safety Reporting and Learning System, which has been going now for over 10 years. And we're currently in the stage of sort of revamping and relaunching that system and tool, with the idea of then getting some more quality data in there that we can then look at and analyze and look at risk and looking to reduce risk and improve patient safety and quality, and also trying to make it a bit more user friendly as well for clinicians, because incident reporting is a big barrier for clinicians. So we can make that a simple and user friendly process. We hope to improve the quantity of data that goes on there, Because when we looked at the last 10 years, it was a very low amount of quantity that goes on there. But we're talking about, clinicians in private practice, and there's different incentives and different structures and governance systems in place. So, we know the barriers there. The barriers are there to incident reporting across all professions, across all healthcare. But that's the other thing that I'm involved with as well.
All right.
So, yeah.
So how if somebody who's listening wanted to get a hold of you or follow you on social media, what are your contacts that you're willing to share?
Sure. So I think the main one is my my email address, and so that's the content is on the paper. So that's just mark.thomas@lsbu.ac.uk. And then also on Twitter, something I should probably use more actually, but I am on Twitter, and my my handle, I think that's the correct term, on Twitter is @CairoMDT, @CairoMDT on Twitter. So yeah, if anyone wants to contact me via either one of those, yeah, always happy to engage with people, 100%.
Awesome. Hey, we really appreciate you sharing your paper. Any final comments to the listeners?
I think really just I think it was just important and interesting to reflect on the conversation we had about different professions, and really I think one of the values of research is can work across different professions, and that interprofessional aspect, or especially something like manual therapy, where we can have input from all professions, and it's not just one profession specific and dominate, such as physiotherapy and or chiropractic or osteopathy. So for me, I think that's one of the benefits of the literature and research, to be able to work across interdisciplinary and get the best results for our patients.
Couldn't agree more. And in fact, the more we collaborate, the more we realize we do pretty much the same thing.
Exactly.
Mark, thanks again. Really great paper, and appreciate your time.
Thanks, Chad. It's been really enjoyable. So thank you.